and their contact info in the chat as we get the recording done. Just to kind of introduce everyone and kind of, see where everyone's at and, just to kind of build that sense of community here. Because I know there's some of us that know each other and there's some of us that also are new faces to one another too. So if you haven't been to a forum before, welcome. If you have been, welcome again. We'll kind of operate this pretty similar to as we do in the past. We have three incredible speakers who are here with us this evening, and we have a set of questions that we'll ask them, but also at any time, feel free to ask the speakers questions. You can put them in the chat. We'll watch the chat and kind of add those up into the queue to make sure everybody gets heard at some point or another. And otherwise, we'll try to be mindful of time and just kind of go up to the hour, but we also know that there's lots of fruitful conversation that comes out of this time. So we will be mindful of everybody's time. This is recorded, so we'll share it out with everyone. If you have colleagues and folks that missed it that you want to share it with, feel free to do that as well. But I'll introduce myself first. I'm Allison. I'm one of the co-chairs of the PT Public Health Forum team. So you see emails, social media posts, things like that from myself, along with Jeff Hartman and Leah as well. And so without further ado, I'll go ahead and introduce our speakers. So our first speaker today is Dr. Megan Mitchell, PT, DPT, MPH. She's been practicing since 2010 after finishing her DPT at the University of Colorado. Her first 14 years practicing were at a level 1 trauma center, where she was the lead PT for the adult and pediatric trauma ICU and the lead PT for the emergency department, covering adult, pediatric, labor and delivery, and psychiatric EDs. She was able to assist in the rewriting of the facility mass casualty response practices to be disability inclusive and gender inclusive. In 2024, she finished her MPH with an emphasis in global disaster management, homeland security, and humanitarian aid. Her current professional roles include associated faculty with the University of Colorado PT program, emergency operations specialist with the National Disaster Medical System, senior rehab tech specialist with humanity and inclusion, PT responder with humanity inclusion foreign medical team, instructor in emergency response for the athlete, and staff therapist in a hospital. During her downtime, she volunteers at the Marine Corps Marathon, where she gets to spend time with some of the best people she knows, and she fosters rescue puppies. So welcome to Megan Mitchell.
Hello, my name is Leah. I'm the other co-chair for the PT and Public Health Forum. I would like to introduce our second speaker, Miss Lori Baxter, coming to you from Mexico City right now. Lori graduated from Emory University with a dual DPT MPH combined degree in 2010. After several years providing inpatient and outpatient PT to children in DC and Oregon, she transitioned to global health and international development. Lori was the technical coordinator and technical advisor for early childhood development and rehab projects with Humanity and Inclusion and Save the Children in Laos and Cambodia. Since late 2020, she has worked remotely from Mexico as a disability inclusion and ECD technical consultant for international NGOs. Lori is now balancing consulting with road schooling her young sons as she lives and travels full-time in an RV with her family. Lori, thank you for joining us today.
And our final speaker is Laura. Laura has extensive international experience in public health and physical therapy. During an MPH internship, Laura worked on the Rosebud Indian Reservation in South Dakota, interviewing community members about culturally appropriate diabetic foot care. Laura has also spent a year in Thailand as a PT trainer, working with children with developmental disabilities in northern Thailand and providing care for Hmong refugees in the Ban Vinai refugee camp. Laura has lived and worked in Auroville, India, mentoring community health workers, providing home care, and volunteering with Mother Teresa's homes in Calcutta. Since 1992, Laura has been affiliated with the Center of Victims of Torture, serving as a PT volunteer in Minnesota and as a clinical advisor for programs in Kenya, in Nairobi, and in Kakuma refugee camp, providing a bridge between Minnesota headquarters and the refugee and Kenyan PT and rehab staff. Laura has led trainings and helped with the creation of specialized group and individual PT sessions LGBTI PT counseling aftercare groups, and PT counseling parenting groups for traumatized refugees in Kenya. So welcome to Laura.
To start things off, we're going to ask a question to the panels, and we'll start from Megan, and then we'll go to Lori and Laura. First question, what motivated each of you to choose a non-traditional career path such as the one that you currently have?
So I was being consulted in that. So at the time I was working in a trauma hospital and really trying to push for more inclusion of PT within the emergency department. And I think a lot of people knew and understood that there was added value because we'd been sort of intermittently helping out. And at the time that I was trying to build the program with them, I had taken a con ed course that was specific to emergency response so that you could sort of reframe the lens of PT practice to that more rapid care, critical care, that frontline pre-hospital environment. And it happened the same weekend that Hurricane Harvey made landfall. And everything I was seeing on the news and in the media made me ask the question, like, why are we not there? And from there, I kind of started looking at what was out and what was happening, and there was nothing within the United States. Like there were some articles and education out there on the emergency room, but nothing on PT in disaster or in an emergency environment. And so I really had to go international to try and find some of that. So that really kind of pushed me in this, well, all right, if nobody else is doing it, I'm going to do it because now I want to do it. And that's how I sort of got started on this path of like what I like to do and changing the environment to fit more with what I would like to be doing more long term. So that's how I got started.
And I can share my story next. So after undergrad, I studied exercise science. So it was kind of like a no-brainer that I would pursue physical therapy. That seemed like a really obvious path. But I decided to join Teach for America first. I was kind of deciding between the Peace Corps or Teach for America. And I remember a Teach for America recruiter saying, because I told her, like, well, I want to go to physical therapy school eventually. I want to be a health provider. Like, why should I do Teach for America? It's education. And she said, well, don't you want to know, like, what happens before children, for example, or adults, like, make it through a clinic doors? And what she said really stuck with me. And then that's something that I got to witness firsthand. I was a bilingual elementary teacher on the Texas-Mexico border. So my first and second graders were dealing with food insecurity, parents who were illiterate, a lot of the challenges that come with a low income area. And so that really shaped my view. Okay, I still want to go to physical therapy school, but I really want to think about like the whole person, like the socio-ecological model. How can I do that? And combining it with an MPH seemed pretty obvious. I don't know who first planted that seed, but it was just something that I knew from the beginning of my time in Teach for America I wanted to do. So as I was applying to PT school, I was really just looking for dual degree programs, or at the very least asking every single program, okay, well, what do you do with people? Like, what kind of service learning do you have? I didn't know it was called service learning at the time, but that's what I wanted to get at. And I really wanted to find out how we could help to make sure that rehab services were available for people who did not have insurance, for example. So fortunately, Emory was starting a dual degree program, so I was able to enter. So from day one, it was kind of always shaped my career path. I knew I would practice clinically in the US, and then I knew I wanted to do something in global health. And later, I'll be able to share a little bit more about that career path. But for me, it really started from that exposure to thinking about all of the various factors that are determining someone's health.
And then for me, right after I graduated from UW-Madison, I moved to Israel for a year and worked as a physical therapist there. And a lot of the people there were immigrants and refugees from all over the world that had settled there. And I found I just had a real passion and affinity for working with people from different countries. So then when I moved to Minnesota, I started taking classes at Minnesota International Health Refugees and like seeking out as many opportunities as I could for international work because I felt like I really came alive. And then what I also ended up doing was I wanted to like find out who are the most underserved populations like in Minneapolis and St. Paul. So it was like, starting to create a physical therapy program for healthcare for the homeless, and then stumbling upon Center for Victims of Torture during a um, international healthcare in Minnesota class I took at University of Minnesota. So just kind of like a lot of kind of happy accidents of stumbling upon people and then finding out they didn't have any physical therapy, but were really interested in physical therapy, or like doing home care for this one company and then going to a housing project in St. looking for the bathroom and then finding out that they could use like physical therapy with refugees in that housing project, just kind of things like that. Just finding out that even in Minnesota, there's like so many refugees and so many needs and such a shortage of physical therapists that are working in those kind of underserved populations.
Thank you all for sharing that of kind of the different pathways that brought you where you are. I always find that interesting of like how did people end up kind of to the path where they're at? And with each of you being in your roles, my next question I have for you is what is the biggest challenge that you find in the role and when you're working within your communities? But also on the flip side, what is the biggest reward that you each feel in your roles?
I can jump in and go first just to change up the order. For me, the biggest challenge now, I practice as a technical consultant. So all of my work is literally from my computer for the past 3+ years. I'm not in the field. I'm not visiting rehab hospitals. I'm not in developmental clinics. So it has been a huge change and challenge to no longer have that direct patient care that I was used to for many years. But at the same time, the reward. So the challenge is that I don't have that experience anymore that I used to. And if I were to go treat a patient right now, I'd have to kind of, remove some rust to remember how to do everything. But the reward is that things are just on a different scale. So within, for example, Save the Children, which is the largest pediatric international NGO, now I'm able to share what is rehab, and I'm sharing it with people who maybe studied nutrition or education or child protection or social protection, and maybe they know nothing about rehabilitation. And of course, it's different in every single country in which Save the Children works. So that is an added complexity. So I think the reward is just continuing to share the word about how rehab in general is so great and how it really truly a right for people with disabilities and adults and children alike. And so that's what keeps me going every day.
Can you guys hear me? My internet's going a little, okay. So for me, being a PT in this country, doing something that's non-traditional, like the emergency and disaster, I find it terribly frustrating that our colleagues in healthcare and literally everywhere else don't understand what we do, what our capabilities are, what our skill set is, what our licensure means. And so having these conversations with decision makers is like starting over. Like, what do you know about PT? What do you understand about PT? And fixing that in a lot of ways. I think some of the biggest feedback that I've gotten from like program development folks is that they think that we walk patients or we do, knee replacements, and that's about it, because they're pulling from their own experience or what they've seen. And I think that to complement that, I think that we do a terrible job at advocating for ourselves. So when we are documenting patient care and the language that we use, it's a lot of the patient walked or we are walking. And so they hear that and think, oh, you walk people. So having to re-educate everybody and make it better, I think is just terribly frustrating. I think for me, the biggest wins are when people recognize that there's a skill there and are willing to at least have the conversation. So for me, it's that moment where they're like, okay, I can see what you're saying now.
And for me, I think the most frustrating and heartbreaking thing is being grant dependent. Like our Center for Victims of Torture programs in Kenya, we were in 2 different refugee camps, and in Nairobi, we had 150 refugee and Kenyan staff. We were serving so many clients with both physical therapy and counseling, and then we lost 95% of our funding in 2020 around the time of the pandemic, and just so heartbreaking when like almost all the staff were laid off, the programs closed, and that kind of thing. Like the need was still there, and the money no longer was. And even with like Anna Selfest and we're creating a Minnesota Center for Victims of Therapy physical therapy program, and we even have the billing down. We're billing Minnesota MA. We're integrated in the EMR. We're getting referrals, and she and I are both volunteers because there's not funding. So that kind of thing is so frustrating. And right now we're applying for 3 grants, PCORI, NIH, Medica. Hopefully we'll get funding, but that kind of thing, it's like, it's kind of like there's a huge role for physical therapy. We've published, we've shown it time and time again, but like kind of getting that buy-in and getting the respect as a profession. Anyway, but the most rewarding thing is when people do get it, and when people are really excited, like, oh my gosh, the clients are getting so much better. They have so much less pain. People are really improving. Wow, physical therapy is making a difference. It's like, yes, when they get it and when the clients get so much benefit.
Those were all tremendous highs and lows, all very, very different, but a common theme of definitely buy-in being really, really difficult for as long as we've been a profession in the US. Getting that across to the layperson is still really, really difficult. I'm now going to open it up to everybody who is attending in the forum. If you want to turn your mics on, if you want to ask your question into the chat function, the floor is yours. I'll give you a couple minutes.
I'll ask a question. Kind of going off of the highs and lows, what are some skills that you would recommend further enhancing or developing or getting more training on, or from my perspective, integrating into the curriculum somehow? What are some kind of key skills you felt like you really had to enhance or develop throughout your career that sets you up for success in the work that you're doing?
I think for me, differential diagnosis is hugely important, especially when we're talking about mass casualty. The vast majority of survivors of any sort of catastrophe, whether that's an active shooter or an earthquake or a hurricane, the vast majority of survivors will be walking wounded. And I think this is like the biggest place where PT needs to step in and shift the burden of care off of our intervention specialists with nursing, paramedics, and MDs. We should be taking on these patients because we understand injury and medical screening and recognizing urgent versus emergent situations. And even if they're walking wounded, they're still going to have medical needs. Those just get pushed back later and later. And that is when we start to see this cascade of secondary injury and disability. So I think that's the biggest place for me. So differential diagnosis is the first one. And then I would also say splinting. So medical splinting in particular.
Did she freeze up on you all? Yeah, bummer.
Yes.
Yeah.
Meg, I think you froze up on us, unfortunately. You're talking about splinting, medical
Oh,
splint.
okay. Did we get the differential? Okay, and then I was gonna say splinting, which we see in sports, but certainly is totally applicable in mass casualty and acute care.
I can go next. I think one of my most valuable classes from my days at Emory, if I just think about the PT program, was the interpersonal communication class. And while it's really painful to like watch yourself be videotaped while you're having a discussion and analyze how you are counseling and communicating effectively, I really do think that those skills have been very critical in the work that I've been doing, particularly, if you are based in an area where you're regularly interacting with people who don't have the same background. It is very important to think about how you can always respectfully communicate. So those skills, whether you're talking about rehab or something completely different, they are very fundamental skills. So my interpersonal communications class is one. And then the other thing that I had thought of was like what can be useful that maybe is not part of curriculum, but could be something that people should work on. And that is just kind of keeping an ear to what is happening at a global level relating to strengthening rehab in the health systems. So the World Health Organization is doing a tremendous amount, and so much has been done in the past, especially since 2015, I would say. And so there's just every day there's new publications and there's so much momentum. But I think as a PT student in the US, you could very easily never ever hear about any of that. But at the same time, that's really what's helping to elevate rehab globally. So if you're interested in practicing globally, you need to be aware of what's going on in that scene as well.
Lori, could you put in the chat like some good links that people could go to or follow, perhaps? Thanks.
Yeah, and for me, I made a list, trauma-informed physical therapy approaches, mind-body approaches of physical therapy, mental health and physical therapy interplay, more about pelvic floor, cultural humility, self-regulation skills, because a lot of times when I would go to like the refugee camp in Nairobi and there was just really intense stuff going on, sometimes I'd feel myself getting a little dysregulated. Those are the main things. And I think really understanding too, like when I started going to Kenya twice a year, I know a Kenyan psychotherapy co-worker told me, like, never forget Kenya is a post-colonial society. So every time you as like a white woman are speaking, just don't ever forget like that the country is still recovering from being colonized and you can represent that. So just kind of, interact very mindfully. And I think that was really helpful to learn.
Awesome tools in the toolbox. So what's cool about listening to all of you speak is that you didn't really talk about using any one like physical resource, like a notebook or TheraBands or anything like that. For all of you, it was really your knowledge and critical thinking skills, which I think really translates to just about everything we do as physical therapy. And as a profession, and our critical thinking skills and our adaptability are some of what brings so much value to any team that we try to integrate into. I will ask the next question. What was your biggest learning curve when you started in the roles that you have now?
For me, I would say it was lingo. So I'm kind of using the role I have now more broadly because now I'm a technical consultant, but for international nonprofit organizations. And before I was a field-based technical advisor, again, for international NGOs. So I'm using that kind of more broadly. But for me, it was like, oh, SWOT analysis. Yeah, I think I kind of know what that is, but it's not something you talk about in PT school. And there were a lot of other lingo having to do with project management that I just had no idea, but I kind of had to fake it and act like I knew what I was doing in order to save face, but also just because, I was new to this role. It was a big transition. So for me, there was just a lot of lingo related to international development. Fortunately, I could pull upon my husband's expertise since he has a master's in it. But if not, Google is your friend. And of course, being humble and just asking if you don't know something.
I think for me, it's learning to write program objectives, like not just SMART goals, but like program objectives, and making sure that I'm not micromanaging the field teams as well. I think that being able to step back and see it from a higher view is a little bit challenging. And then understanding disaster risk reduction and the programs that surround that.
And for me, I think it was helping with the grant writing that before, and then like how to help start a program from the ground up in Nairobi and in Kakuma refugee camp. It was like nothing. So kind of how to work with research and admin and counseling and the whole team to kind of create something from nothing. And then how to advocate for physical therapy without being a squeaky wheel. Because I got feedback from one supervisor that, Laura, every single meeting, what about physical therapy? What about, so kind of like how to do that, but in a really respectful way that doesn't alienate other people, just somebody, so it's that frustration of how do they not get it, so that. Yeah.
I'll pause too in case anyone else has any other questions before I kind of ask one that kind of off the cuff, but one that I thought of I wanted to ask.
I wouldn't mind bringing attention to Megan's comment in the chat. I want to learn how to write a grant. Does anyone have any suggestions as to how to develop your grant writing skills?
For us at the Center for Victims of Torture, there was always a big team, people from research that would talk about, objectives and indicators and what like sample size would we need to show this and that, and then like responding to what the funders were looking for. And it was always clinical team, admin team, research team. And usually there were a lot of people that had a lot of experience and they would kind of delegate, and then we would pass sections around and everyone could give input. So yeah, I wouldn't know how to do it from alone, just as part of a team.
So I didn't get a public health degree, but I guess I just assumed that in any public health degree, either master's or doctorate, that would be part of the curriculum. But I guess I'm wrong.
It was
Speak to
not
what
part of mine.
No, we had one course at Madison that was on like planning and management to promote health. And I think the people to learn from are like the people who work more at that like local level of public health, that community level of public health, where like their job is just grant writing. And so, I mean, we had a group project writing a grant, but it was with like 4 or 5 other people and having like a really detailed guidance of like from someone in the field who's done it. So I think like the advice is also like finding those people that are maybe not specifically within healthcare on our teams, but where part of their role every day is like being local and like writing those grants and like finding out who those people are in your community because they often know kind of what that framework looks like, but it takes a lot of time to kind of like weed it out and kind of get the format exactly how they want it.
And I would just add that regarding grants, maybe it's helpful to kind of dig a little bit, find out who has succeeded in getting the grant that you are applying to, reach out to those organizations, see if maybe they're willing to share at least maybe a redacted version of the successful grant so you can see if they're not applying again, you can see what one looks like, because I think it really like you need to see that template.
My other question I kind of had for you all was we've kind of talked about different pieces of some of the teams that you've been on and kind of working on those interdisciplinary teams or, branching out and working with other community groups. And so I'd be curious to hear kind of all of your unique insight of what you've kind of your reflections and takeaways from being on these teams and kind of what value, you as the physical therapist are bringing or like how communication has maybe been like something that's been a challenge or a barrier and just kind of how you've navigated being on different teams in your roles.
I can answer from one perspective, that of like actual field-based implementation, because sometimes as a physical therapist, you're the only physical therapist that's all supporting a child. And so in that case, it's like reaching out to OPDs, organizations of persons with disabilities, and leveraging their networks, especially if it's a more hidden population that you're trying to access. And then we found a lot of success in Lao working with caregiver support groups, specifically for caregivers of children with disabilities. And they were so eager to hear directly, from a physical therapist and get suggestions on how to better position their child so that they didn't get contractures, even if they didn't know that that was the word for muscle tightening, or how to position their child so that they could feed, swallow without choking. So that's where I feel like kind of balancing, okay, there's already a technical officer that's Laotian that's here supporting them, but as a physical therapist, I can bring another perspective. And also not necessarily having to speak the same language to communicate that, but doing that through demonstration.
Yeah, so in disasters, I think the biggest lesson that we come up with every single time is that communication is the biggest failure across the board. I think that being very intentional about when you're working in the environment and when you're advocating in that environment, making sure that you are addressing the needs of or the skill set of PT, but also addressing the needs of disability inclusion, just addressing what would be a typical emergency response process, and then making sure that we aren't just catering to the able-bodied adult, which is where a lot of our emergency response and plans tend to fall. And so just, I think the added value is that the lens that we have as a PT not only addresses some of the legal requirements, but it also improves response for those who are most vulnerable.
Yeah, and that's such a good question. And I think part of what worked well was when we would work really closely with a refugee advisory group, like both in Minnesota and in the refugee camp and in Nairobi and that kind of thing, to really find out, don't lose the voice of the actual impacted refugee population, make sure that those individuals are included. And then working with other NGOs, like in the refugee camps, we worked a lot with humanity and inclusion and kind of like, okay, how do we refer to each other? Like, how can we do workshops with each other to like share information about disability and about trauma? And, even when they were PTs in different organizations, like our skill sets would like overlap but complement each other. So how we can like learn from each other and grow.
As clinicians trained in the US, how do you adapt your plan of care operating in another country with a different continuum of care and access to physical resources?
I think I can start. So when I was practicing in St. Lucia, I didn't find that it was a big issue. So the providers there were trained in the UK, which was helpful since the educational level is sort of up to what we would consider an international standard. So I didn't find that to be a challenge. I did find the discharge planning to be the hardest part because here there's a lot of continuity and we have access to DME and assistive technologies, which is helpful. I found when I was in Ukraine and when I was in Palestine that the first conversation that I needed to have was, what is the scope of practice here? What am I not allowed to do? And what are the levels of care that are already in place? So what do we have access to here? And then making sure I'm not pushing what I feel would be appropriate in the US environment onto somebody else when it's not there.
And I can share some experience from one of my previous roles that I haven't mentioned. I was the rehab director for community-based rehabilitation program at Hillside Healthcare International, which is an NGO practicing in southern Belize that offers free medical services. And during that experience, I think one of the main things that we noticed was we would provide a PT session, and you get to the very end of the evaluation, and then the patient says, "Thanks, where are my pills?" Because they expected that they would walk away with a little baggie of some medicine that's going to magically help them feel better. So quickly we realized, okay, we need to totally reframe from the beginning the expectations. What does a patient expect from a physical therapy session? Who are physical therapists? What do they do? What will we be asking the patient to do? And having that discussion before even beginning the evaluation, because we wanted to completely eliminate that question, but also to maximize the session, because in that setting, there were a lot of initial evaluations and very few follow-up visits. So we knew we had one chance to impart the most critical piece of information that we could. So we really had to prioritize, if it's a home exercise program, give them one exercise for one impairment or functional limitation that we're noticing, but not a whole slew of things, because then nothing will be taken up.
I think for the work in Kenya, initially, Kenyan PTs were trained. It wasn't a bachelor's degree program. It was more like a 3-year program. And then gradually now people are going back and getting bachelors, and a lot of people like study in like South Africa and other countries and get masters and doctorates and that kind of thing. But just kind of realizing that the entry level education for some of my coworkers was different and a bit lower. And yeah, the same kind of thing of some clients wanting more passive modalities, but then once people got used to the role of PT and like what they could really learn from it, a lot of the clients really bought into it. And this is a little bit different from the question, but like a lot of our work in Kenya was group physical therapy sessions that were very manualized, but then you try to tailor and individually adapt things for clients, and then how to include things like for a male group, like including exercises that could be beneficial for erectile dysfunction, even though like not all the clients were dealing with that, and not all were survivors of gender-based violence, but many were. Like just kind of finding ways to culturally include things that would be of benefit. Yeah.
And I was going to type it, but I'll just add real quick. I think the great thing about providing rehabilitation, physical therapy, or otherwise in other contexts outside of the US is that you oftentimes are not constrained by insurance and reimbursement rules. So yes, you can co-treat, treat together, treat for as long as you want, have a session as long as you want it to be, do a group session, and you don't have to bill. You don't need to worry about that. And that is very liberating and really does allow you to then do what is truly best for the patient using the resources that you have available.
And I don't know about you guys, we didn't have OTs in country. I think in Ukraine, I had met maybe 3 OTs and 1 speech therapist. So you really did have to be all of those things within your knowledge base. So a lot of the time, I know we don't really do that in PT school, like, please don't do this if you're teaching. Don't teach the arm as OT. I really absolutely cannot stand that. But you really had to be like the muscles of the neck and the muscles for swallowing and the coordination pieces of all of that had to be part of your skill set. So you couldn't just hand it off like, oh, an OT will do that. You really had to own that.
Well, Laura, that's so interesting. Very cool. All right. What advice would you give to physios who want to break into these spaces you work in?
I would say connect with people, find people on LinkedIn, maybe people from this group, other people you meet along the way, leverage their networks, ask them who do they know that they can introduce you to, ask for informational interviews. The worst that someone can say is no. They're not going to take the time to talk to you, but the best that can happen is that they want to talk to you, and then you can just pick their brain, and maybe down the road you'll have another reason to reach out. So I would say definitely always be creative with what your career path might look like, be willing to take twists and turns along the way, and keep up those networks, because you never know when you might need to reach out to that person that you met many years ago, because it is relevant to the work that you're pursuing.
I love what Lori said and echo.
I completely agree with Lori as well. Definitely make those connections. If you're going to do emergency or disaster within the US, be ready to have a lot of frustrating conversations and, roll up the sleeves and throw some elbows, because this system here is so convoluted and messy that there is no clear path.
What are some of the key relationships that you have made in either your deployments or as your time in a leadership role that you think are valuable lessons?
I'm not sure I have one. I would say anybody who's willing to have a conversation about PT without telling me that I'm walking a patient will be my new mentor. I've already declared it, and they will do that. I don't know that there are key relationships within the US based system. I think you really just need to make the relationships with anybody who is in a position of decision making.
And I don't know if I'm answering the question exactly, but coming along the lines of like mentorship and relationships to help you know that you're on the right track. I think for me, when I arrived in my new role in Lao, and there was a rehabilitation stakeholder group, and all of a sudden I met other rehab providers who were potentially trained outside of the US, but were engaged in work that I was passionate about and wanted to do. It was like, oh, I found my people, and those are relationships that I have kept up, and especially some who were several decades ahead of me professionally. I really have found it useful to continue to keep that network alive and keep that relationship healthy, so that I can reach out to them, ask them questions, ask them for contacts. And that's something that is kind of scary and hard to do when you're not yet sitting around the same table.
Yeah, and for me, I think it was some of the other clinical advisors at the Center for Victims of Torture, whether they're the physical therapy clinical advisors or counseling clinical advisors, or just kind of that international network. And like we co-created a Facebook group for physical therapists interested in working with survivors of torture and other forms of trauma. And for a while, I was really gung-ho and helping coordinate the group, where there are like 220 people from all over the world. I think we had like 35 countries, and the group still exists, but I've not been as active on it. But just kind of finding that excitement and the passion of people all over the world that like really want to work with refugee populations, for example.
I'm just going to add, I really love getting those emails when people are like, I like what you do. I want to do what you do. I feel like that's incredibly validating that I'm doing something right and other people are interested. So I think those are my favorite.
My next question I have for you all, it can be answered kind of in a number of ways, kind of depending on which form you want to ask. So I have this like kind of big, vague thing I'm going to try to narrow down. But whether if you're thinking about, networking with these groups, lots of different individuals within our profession that we talked about, or if you're thinking about many of the challenges that you face in your roles that you talked about earlier, how do you begin to start to narrow down of where to begin? Of like, where do I start? Whether it's like, who's my point person that I start to try to figure out a solution here to this challenge? You all have talked about like very large and complex, very upstream challenges that you're working with. And so I'd love to kind of pick all of your brains to figure out like where does your brain go and how do you decide of like where to start first?
I mean, for PT in the US in disaster, because it's not a thing, I took the shotgun approach and did literally everything that I could to get the education and to test the waters, so to speak, and figure out which areas I actually like to practice in. So for me, it was everything and not limited. But now that I'm a little farther out, I can start to narrow it down just a bit more.
I can take a slightly different twist in answering. And I'm thinking about like, for me, since most of my work has been centered around pediatrics, if I think about a given child, which within Save the Children, we're often talking about an individual or a group of children. And then I think about like what is surrounding it? What's the programming that is available to that child? And what services is Save the Children already providing? It's not going to be rehab. Okay, so how can we convince those who are already providing the services that rehab is important and that we should at least be screening for developmental delays for early detection. We should be referring for early intervention. And what are those referral pathways? So for me, it's kind of like, that's that whole child approach of who are the influential people that are making decisions about, that child. And even if PTs are not currently involved, how can we kind of push the envelope a little bit to get it at least on the radar?
Yeah, and for me, it's like working with Anna Sylvester, who's on this call and everything, and that we're trying to create physical therapy for the Center for Victims of Torture in Minnesota, and that was, figuring out the billing, figuring out like what codes to include, the billing codes, figuring out diagnosis codes, like how to get buy-in from the staff. And like for many years, I was trying to kind of be like, wait, here's all this research about the role of physical therapy, kind of what's going on? Like, why can't we move forward? And then finally it was like, wait, why don't we develop a survey of all the clinical staff of CBT in Minnesota, like the counselors and social workers and nurse and that kind of thing, nurses, and ask targeted questions like, oh, how many of your clients have pain? How many have issues with like sexual dysfunction, sleep issues, kind of like having the groundswell, like, oh, the survey showed 80% of the people feel that there'd be a role for PT. 90% of the people note that their clients have a lot of pain, kind of like trying a different, like, wow, the staff at CBT is identifying the need for PT rather than me as a PT saying that this needs to happen. So kind of figuring out a different approach, like being more strategic.
Any other questions from the group of attendees? The floor is yours.
If anyone is interested in working wildland fire medical operations, I think I have figured out the pathway. I'm just saying.
So documentation is understandably different for everybody who's not operating inside of the US in a medical role. I'm curious, what do each of you do both in a patient care sense so that you can communicate with others? And then also, what do you do for documentation to support getting future grants?
I think one topic we haven't discussed yet is specifically assistive technology. And I think if we're considering like grants, something really tangible, and then especially if we're talking about international development, I think figuring out like what are the numbers, like how many people, how many assistive products are being dispersed, for example, and who are they being dispersed to for what types of functional limitations. That type of data, I think, can be really important to document because maybe it's a little bit more tangible than numbers of, treatment hours or treatment visits.
So documentation in St. Lucia was very much the SOAP note format, which is super helpful since I was pretty young when I went out there to do that work. I would say for the stuff that I did in Ukraine and for Palestine, the company that I went with, the NGO that I went with, has a tracking system for pathologies and assistive technologies and age and some of the basics that you would want to track, just to make sure that we aren't doing program creep. But I don't know that documentation itself was practiced in either of those clinical environments. I don't remember anybody actually writing notes for documenting the care that was provided.
Yeah, and for us, CBT, physical therapy, like over a period of many years, we created an extensive evaluation tool that we use in Kenya, Ethiopia, and Jordan. So we were able to just use the tool because it was like holding it together really well from a research base, and it works really well in US setting. And then we just do more like a SOAP note for the ongoing note. So that worked really well. We didn't have to recreate that much for documentation.
I have a question that might be mostly for Megan, but I'm curious because I'm not really understanding what the PT's role would be in disaster relief. If it's more of treating the people who are affected by the disaster, as you might imagine for like a flood, or treating the people who are responding to the disaster, which I imagine would be the firefighters.
Both. You should
Does
be
it,
doing both. So actually, we had a dentist on the team for the system in the US, and the dentist treated as many survivors of the disaster as they did responders. But I think we need to address both, which isn't being done. So I'll just elaborate more. So for the wildland fire medical operations, you would just be treating the firefighters. So it would be frontline in the fields, not on the teams, not embedded like you would see in the military system, but you would see a frontline, a field medical hospital, not hospital, clinic, essentially, in the forested area that's on fire, where you would just be treating your firefighters as they come off the front line. Everywhere else, the large majority of what you'll see is the survivor in the community, but we really should be treating our responders as well. There is zero data on their injury patterns. I have found one on wildland firefighters.
yeah, and I know especially in that career path that it is common to have a lot of injuries. So that's really interesting. Thank you.
Yeah, you're welcome.
Last little bout of crickets if anyone has questions in the audience before I jump in. how about to kind of round things off, if everyone wants to kind of share, like, what's one piece of advice that you wish you knew, or you want to give any parting wisdom to the group that's here on the call tonight?
I would just say you're definitely not alone. It is so exciting that this group exists now because it didn't several years ago. And it's just really exciting to see so many people interested in the intersection of physical therapy and public health. But even outside of the US, just know that there are a lot of people who are also very passionate about this subject, passionate about rehab, underserved communities, how rehab can be part of health systems. So you're certainly not alone, even if you are, an aspiring DPT student or a current DPT student who's like deep in the throes of all of the details. Know that there's something bigger and broader out there as well.
Yeah, and for me, it's just how fun and rewarding. I've been a PT now for 41 years, and it's still like really fun and really inspiring. And I think that two things I've learned are just being a lifelong learner, like keeping on learning, staying abreast of the field, and like self-care, like finding different practices for self-care. Yeah, really important for me.
I think for me, the big thing to think about is I didn't go into PT to do TheraBand and hot pack programs. That's not why I'm here. That's not why I went to school. That's not why I'm paying off my student loan still. So you got to do what you love. And if what you love doesn't exist, be willing to put yourself in that space and create it for yourself. As far as US based disaster and emergency practice, there's a whole lot of free continuing ed out there. And you all got student loans already. So if there's free con ed, let's take advantage of it. But there's clinical and non-clinical roles that are begging for the lens of a PT to improve practices. So I think there's so much out there to be excited about in the way that we can get involved. Don't limit yourself because somebody else told you to.
All right. Thank you so much to all of to the speakers, to everybody who's joined, to everybody who's asked their questions. We hoped you learned a little bit and got to meet some other people who are passionate about the same things that you are. We are a small but mighty number. So hopefully this space has given you something that, you were missing in your life. If you would like to keep up with some of the people that are on here tonight and would like to learn more about their passions, their interests, some of the roles that they hold, there is a networking Google spreadsheet that we've been using, and everybody has just been updating their contact information, their interests, and things like that. So we strongly recommend that you take a look at that and update your information on there just to make sure that you can collaborate with all the people that you want. And secondly, there will be a feedback form that you will receive via email. We would greatly appreciate if you would give us your honest feedback. We try and learn every single time we do these forums how to make it better for all of you. We are volunteers, but we do take the time to read through all of the feedback to come up with a way to do it better, such as having it on a weeknight instead of a Saturday morning, things like that. So be honest. We appreciate your feedback, and we appreciate the time that you've taken out of your Tuesday night to join us. So thank you, everybody, and have a great night. We will see you next time.
Thank you.
Thanks all.